Welcome, everybody. Thanks for joining here. We've got a good group. We've got 28 attendees. Just want to thank Dr. Levine for taking the time and doing this presentation. We host the fellows, the Hip and Knee Fellows course, which I believe quite a few of you attended this past February, March in Tampa. It was a great course, and one of our sponsors at the course was Link Bio, who are now sponsoring this particular presentation. So thank you to the group at Link Bio for helping put this on. I'm going to turn it over to Laura for a few seconds, and then we'll get Dr. Levine up here presenting. Thanks, Laura.
So I just want to thank everybody for coming on to here. This is our first hip and knee doing. With that, the hip and knee IEP registration has started and is open. The website that will come up after this webinar concludes is where you can register for 2021's course. And then Dr. Levine will be doing our presentation today on considerations for treating an infected PKA. He is from Rush University as an associate professor. Dr. Levine, the floor is all yours.
We'll go ahead and get started with considerations for treating and I also work at Elmhurst as the service line director. I do have a conflict that I do work with the Link company in consulting, and then the rest of my conflicts here, which really don't have any relevance. These are the things we're going to cover. We're going to talk a little bit about the workup of a painful total knee. Then we're going to talk about a one-stage versus two-stage, my typical two-stage protocol, and then determining constraint when I'm doing a total knee replacement revision. How do I make that determination for CCK versus hinge versus a standard PS? So just as a little welcome to the revision world. Revisions are a different kind of animal. The diagnosis of the failed total knee arthroplasty is paramount. You have to know what you're going in to fix to be able to fix it. And patients typically have a different mindset when you're talking about revisions. They just finished having a failed replacement, and so they're usually a little bit more tentative and oftentimes not expecting quite as much out of the procedure the second time or third or fourth time around. Not all revisions are created equal. You must keep that in mind. And with that, we'll just kind of run through a very quick case. This is an 88-year-old. This is an obvious reason for a revision. But the increasing pain over 5 years, progressive deformity, and the deformity was being watched. We'll talk a little bit about the diagnostic workup in a little bit, but this patient went through our standard diagnostic workup, and you can see with the valgus deformity, the patella is not tracking well. Valgus deformity, poor range of motion, well-healed surgical scar, difficulty getting around. And for the interest of time, we'll zip through the case here. This is an intraoperative picture of her femur. We shortened the leg to prevent some injury to the skin and get it closed. We did place her in a neomobilizer for a short period of time postoperatively. And then this is her at her follow-up visit. I don't remember how many years out she was, but we went to a distal femoral replacement to treat that poor bone quality. So that's just a quick case to talk a little bit about the concept of revision surgery, a little bit about the epidemiology overall. Revision rates are somewhere around 12%. There's not a ton of surgeons actually doing revisions. I think last AJR showed maybe 6 to 10 revisions per year for total knees for arthroplasty trained surgeons. The outcome for revisions are getting better, but they're still not as good as primaries with an 80% success in 10 years. And then there's around a 28 to 49% complication rate. So makes it definitely more risky to do these surgeries, which is why I think you find less and less people doing them. The NIS database was surveyed, and what they found is pretty consistent with most of the institutional databases, is that infection seems to be one of the top reasons for revision, followed by loosening, other mechanical problems, implant failure, instability, and then wear, which is lower on the list than it used to be. But overall, there is roughly 8 modes of failure. Revisions are are a high cost to treat, and they're going to be a real burden moving forward, particularly because of the explosion in the number of total knees being done in the United States. The cost is going to be a big burden to the healthcare system over time, which is why we're trying to figure out ways to have one revision and be done and not have to keep revising these people over and over. I think one of the biggest concerns, too, that I have is that Just today, I saw 2 people that had painful total knees, and then when we looked at their preoperative x-rays, they had very minimal osteoarthritis at the time of their surgery, and they basically had a couple injections, a scope, and then went to a knee replacement, and now they don't love their knees. So I think this is underestimated, and I make sure that I get the preoperative x-rays to keep an eye on that. So when we're working up a painful total knee replacement, you want to make sure you do follow an algorithm. I typically go with history, then I'll do a physical, then I do my imaging, usually standard first, maybe advanced, depending upon what I find. And then typical lab studies, there's screening studies and more specific tests, which we'll get into. And that's more of the task they asked me to look at today, was more talk about the lab studies, but we will cover each of these points relatively quickly. So this is the main points that I'm supposed to cover. We want to rule out infection. You should always rule out infection in these painful total joint workups. And then we'll cover the MSIS criteria that's been created, or now the ICM criteria that for the International Consensus Group. Sometimes the diagnosis for revision is pretty easy. When you got an unstable knee that you can kind of place anywhere and the ligaments are out, that's kind of easy. Those are the great revision cases to tackle, and that you know exactly what the problem is. The knee is unstable, and let's go ahead and fix it. But sometimes it's not so easy, and when it's not so easy, you need to start with your algorithm. You got to start with the history. So you need a detailed history, and then try to get the op report so you're sure you know what implants are in there. Then you want to find factors, prior surgery, inflammatory arthritis, diabetes, malnourished. You really want to make sure that you vet all these so you can get the best outcome for your patient after revision. Then as we move into talking about the pain, we want to know the quality of pain. Is it startup pain for loosening? Is it nighttime pain more for potentially infection? Is it pain at rest? It's very important to kind of go through the pain discussion so that you can figure out and maybe get some clues as to what's going on. Onto the physical exam, we want to assess the surgical scar, look at the range of motion, check out the gross alignment of the limb, look at their gait, see if their foot is rotated internally or externally to maybe give you a hint to the rotation of the components. Look at the patella tracking to see if it's subluxing as they're flexing and extending. Check for infusion, warmth, and then obviously instability as you go through. Again, you just want to have a nice algorithm. Go through your physical exam slow and steady so you walk out of the room with a potential diagnosis. Make sure you palpate along the implants. Always assess the IT band. That tends to be tight in a significant number of patients, and can also be a diagnosis that you can determine with an injection or confirm with an injection. Check the vascular status. Always check the hip. Check the neuro exam as well, and make sure you're not treating someone with Parkinson's disease and revising them for stiffness just because they have Parkinson's disease. Then we'll look at our x-rays. Typically, we'll get an AP lateral merchant view. For revisions, we like to get a mechanical axis to look at the hip and the ankle also. New areas of osteolysis and lucency. So if we're looking for new areas of osteolysis and lucency, that means we must have older x-rays. And I can't stress that enough. You really want serial x-rays. Get as many x-rays as you can dating back to prior to surgery, and then immediately post-op, and then the latest issues that are developing. In instances, cases like this, where you have notching, you can get fracture afterwards, although it doesn't necessarily mean fracture. But if a patient is having pain and there is a notch, then I would be careful because that may be leaning towards a fracture in the near future. Other simple x-ray findings, the first one is showing subsidence of the tibial component in a couple different implants that are loose. And then a case of recurvatum where that's clearly instability. And then we have some overhang on this x-ray here, and this person had some pain on the medial lateral side. So sometimes the x-rays can be very helpful. Most of the times for infection, it's not helpful, although occasionally in cases like this, you might see periosteal reactions. The implants might loosen over time. And then if you have a rapid loosening in an otherwise well-done cemented knee, that may be the infection eating away at the cement bone interface. So definitely have seen that in some cases. So you can occasionally pick up infection on x-ray, but it's most commonly done with your laboratory tests. So the focus again for the diagnosis was more of the laboratory tests. We start with an ESR and CRP. These are great screening tools, good sensitivity, relatively low specificity. They're easily obtained, and I typically get these in every case prior to every revision and for every painful knee workup. IL-6 may be playing a role in the future. And then D-dimer is another test that's recently been added, which really hasn't shown great accuracy. But I don't really get other labs except what we're doing our D-dimer study right now. Usually ESR and CRP are my screening tools. If those are elevated, then I'm going to go ahead and aspirate. We'll cover aspiration in a second here, but just a brief mention of the MSIS criteria. This is the old criteria. I usually use this more than the newer one. It's the major and the minor criteria. If they have a sinus, you're infected. That's pretty simple. If you've aspirated and they have two separate tissue cultures obtained from the joint that are the same, then that's infected. The minor criteria, elevated labs, the aspiration, and then some of these things are actually intraoperative findings. But this is more often what I'll use. And usually if a person doesn't have a draining sinus, then they'll have these other things that are positive, like elevated ESR, CRP, elevated synovial leukocyte count, and then the PM&M percentage, and that usually gives me enough for the diagnosis of infection. And occasionally we go into the OR with a little bit of an indetermination, but and we'll make that final determination of infection intraoperatively. When we look at the new MSIS criteria, this is a little bit more burdensome. You got to start calculating things. And if you're not fantastic at math, it may take a little time to get through this, but this is the new criteria, which adds some other factors like D-dimer, alpha defensin, and synovial CRP. But usually for other labs that I may check for my patients, if I'm concerned at all outside of infection, will be nutrition labs, blood glucose status, tox screen, kidney function when those are appropriate. And there are definitely scenarios in our revision settings where those are. If the ESR and CRP are elevated, then I will go ahead and do a joint aspiration. My cutoff is usually around 3,000 white blood cells, although you'll find different ones in the literature, and a differential of about 80% segs. Anything over 90% segs, I'm definitely suspicious for infection. And that means I'll even go a little lower on my white blood cell count if they have that many segs. We send for cell count, crystals, and culture. We want them off antibiotics for at least 2 weeks. We don't send them for the fluid for a gram stain. We do grossly assess the fluid, but that's not a great indication. If there's blood, it could be possible trauma or trauma of the needle stick. Clear yellow fluid is typically normal. Pus is infection. And then if there's a white residue, oftentimes that's crystal related. Other tests that you can get with the joint aspiration, you can do the Luke Esterase strips, although I don't do those very often. You can do synovial CRP, which I really don't do very often either. And then in cases where it's difficult or I'm a little confused, I will send off an alpha defensin test to help me break a tie or give me better determination for whether or not a joint is infected. The alpha defensin test has got a great sensitivity and specificity in the knees. It can be a little muddied with metal debris, but in the knee, we typically don't find that. So I am a big fan of alpha defensin in the cases where I don't have an obvious diagnosis. The Luke Esterase strips I'm not as keen on, but you certainly could do that in your office. So again, I follow that algorithm. Labs are elevated, get an aspiration. The aspiration is elevated, then I'm thinking infection. If it's cloudy, any of the picture, then I'll go ahead and send an alpha defensin. So moving on to after we made our diagnosis, do we do a 1-stage? Do we do a 2-stage? We're part of a multi-center study right now to do this, and so we are randomizing people between the two. But in general, my 1-stage indications are they can't withstand 2 surgeries. There's a sensitive bug on the culture. They have a good soft tissue envelope. 2-stage indications are younger age. They can't tolerate 2 surgeries. Resistant bacteria, poor soft tissue envelope, and either they fail the 1-stage or a prior washout. And then a new concept that we've currently brought to light is doing a 3-stage. This may be a little mind-blowing, but these are in cases where we do an initial washout, and then they either need a wound flap, so they'll do a gastroc or a free flap, and then we'll come back and replant them on the 3rd stage. But also as an indication for extensor mechanism cases that are previously infected, where I'll go ahead, we'll do a spacer, we'll replant them, and then if they prove that they don't get reinfected from the reimplant, and they don't like their function, then we'll go ahead and do an extensor mechanism allograft or a Marlex mesh secondarily as that 3rd stage. So these grossly infected beds, a lot of times we'll do that free flap or a gastroc, or if they have a prior infection and they have an extensor mechanism disruption, then I may consider doing a 3-stage procedure. What's the right answer? There really isn't a right answer. 1-stage, 2-stage, 3-stage. We all kind of make this up a little bit and go based upon our own anecdotes. But overall, there's been good success with the different type of techniques, whether you're doing a 1-stage or a 2-stage. I think mostly it's sticking to your algorithm, sticking to your diagnosis, and then treating it adequately. So doing thorough debridements, coming up with a good spacer if you're doing a spacer, and if you're doing a 1-stage, making sure you really do have a great debridement and you do it appropriately as a 1-stage should be done, where you change instruments, reprep, redrape, and stuff like that. That gives you the better success for doing a 1-stage. So overall, the results are pretty good amongst all the different studies, 1-stage or 2-stage. But I think you just have to base it upon either your own sort of preferences and comfort level. And certainly in some cases, I will force that 2-stage, particularly when the skin envelope is not great, as I mentioned before. So with a 2-stage protocol, I do a standard approach to it. We remove the implants. We do a thorough debridement. And for a 1-stage, this is basically the same to this point. And then I would change out gloves, change out instruments, reprep, redrape, and then go ahead and put a knee on the same day in a nice, healthy, clean bed. But it really does require a thorough debridement. So debride, and just when you think you're done, debride some more. Treat it like an open wound from a fracture. With spacers, we have static spacers. There's functional spacers like this one where I put it in and it bridges the gap. I actually let people go weight bearing is tolerated on this, and sometimes it's sort of their bridge to an arthrodesis. Non-functional spacers where it's not in quite as well. Usually I protect the weight bearing. A lot of times these people need a knee immobilizer externally with a non-functional static spacer. On the dynamic side, I call this more of a dynamic functional spacer where it's basically like a Prostalac. I've coated the stems. There's a ton of antibiotic cement around the implant and very, very high dose antibiotic cement. And then there's the non-functional ones, which I consider this, which is more just cement blocks. These do have some function, but it's difficult with being weight bearing is tolerated. The range of motion is not great and the stability is not great. So I don't consider it quite as functional, and it falls into the non-functional category. The antibiotics that I put in my spacer, I usually put around 3 grams of vancomycin and 1.2 grams of topramycin per batch of cement, unless there's some organism that I have to switch that up for. For fungal infections, we'll do voriconazole. And sometimes we'll just tailor this towards people where we've had VRE and we'll use cubicin or daptomycin in the spacer itself. The patients will get antibiotics for 6 weeks, then 2 to 3 week drug holiday as a minimum, depending upon the skin integrity. If the skin is not great or we did a flap, a lot of times we'll favor a longer holiday. We'll follow the labs. We don't really follow the D-dimer in between. That's only been a screening test at the beginning. Really hasn't been very accurate for us, so we don't really follow it in between the stages. And I think Carlos Higuera is going to be presenting, or at least submitted an abstract to look at this, as we didn't find it to be very accurate for determining eradication of infection in between a stage 1 and stage 2 procedure. And then we aspirate. You can do it either pre-op or intra-op. I usually give the patient a choice, but I will aspirate and send it for a cell count with differential. We're fortunate that our labs are pretty good, so I can do it either intraoperatively or preoperatively. Then we reimplant after a thorough washout and sharp debridement. Again, change gloves, alternate instruments. I try to do some of this even for the 2-stage protocol, where we'll wash it out again, remove the spacer, then change gloves and have a separate set of instrumentation for the reimplantation of the implant so that there's no contamination with the spacer that came out. I'll use antibiotic bone cement, usually 1 gram of Vanco per batch of cement that already has antibiotics in it, or an alternative based upon the prior infection. Put a drain in. Sometimes we'll use a wound vac for these people. Bed rest or immobilize them, depending upon what they had done. If they had a flap or an extensor mechanism allograft, we may need to plan a manipulation at 6 to 10 weeks down the road. And I close these wounds a lot of times with nylon sutures, or I have my plastic surgeon close them if there's any concerns. Moving on to determining the level of constraint. We like to use the least amount of constraint. However, stability is paramount, particularly in revisions. The last thing you want to do is this complex revision, and then you wind up with an unstable knee, and then further problems and having to go back in the knee. This is a case of a jumped CCK type of device. And so, you do this a bunch of times and eventually they're going to get infected. So make sure they are good stability at the time of your revision so that you're not coming back for issues with that. My indications for a hinge, talking about primary knees for a second, flexion extension mismatch, severe soft tissue instability, severe varus deformities or valgus deformities. Morbid obesity can be a case for some of these patients where when they flex the knee, it just pushes the tibia forward and there's just instability anterior posterior. Anybody that has a weak extensor mechanism is a candidate to me for potentially for a hinge. I don't do very many primary hinges. On the revision side, a flexion extension mismatch is probably the biggest reason for me to do a hinge. Failure of a CCK implant, I typically will go to a hinge and don't try to reinvent the wheel there. Periprosthetic fractures, a lot of times you're doing a distal femoral replacement type of thing. So that's going to be a hinge device. And then in cases with 1-stage or 2-stage infections, I'll often use a hinge if the thorough debridement requires removing some of the stabilizing ligaments around the knee. My personal indications, again, for revision knee, flexion extension mismatch not managed with a CCK, CCK revision, and then anytime I need to protect the extensor mechanism, I'm going to put a hinge in. Typically in my practice, I do 100 or so revision knees a year. Early on in my career, I was mostly CCKs and less hinges. Now I'm about 50-50 because I fear the hinge a lot less. I definitely have treated a lot more extensor mechanisms, function issues. I've treated recurvatum issues more frequently because a lot of people don't like to deal with those. And then shortening of the leg is something we've had to deal with so that we can get the wounds closed. So at this point, I don't fear the hinge so much as I used to. I definitely fear it a whole lot less. And so that's why I've made this change. When you look at the historical series, hinges have had pretty good success. CCKs have had pretty decent success. But at 10-year failure rates, at 10 years, we start to see some failure rates because of that added stress. And I was getting tired of these radiolucent lines that we were seeing in a reasonable number of cases, or slow migration of that tibial stem, even with pretty well fixed implants. You can see them start to migrate, and that's led to the use of more of cones and additional fixation so that you can avoid those radiolucent lines. But I think the rotating hinge also helps some with this, in that you don't get this post wear. And I see this not infrequently in some of these CCK devices, but the post gets a lot of stress that transfers into the tibia, and that's when you lead to the ultimate loosening of the tibial component. And you can look at the backside of the CCK, you can see a lot of scratching, you can see indentation. So there's a lot of stress on this poly here. And I think that sometimes gets underestimated. And I think when we tilt the poly a little bit more, you can see on the left side of the screen, there's definitely some windshield wiper happening here. So there's a lot of rotational stress on these implants. I think that's been underestimated. And so I think that's something that has to, you really have to consider when you're doing your CCKs and long-term balance of the CCK. So I really think ultimately, though, we need more RCTs. We need randomized clinical trials so that we can get good comparisons of cases that are appropriate for both. Most of the time, the hinges don't get an unfair shake. They basically are the worst cases, and CCKs sometimes will get, or most often get, the easier cases. We also have enhanced fixation devices like cones, sleeves, and on-growth stems. So those are also things that may enhance the fixation and decrease the risk for loosening for these implants. And maybe people will be less afraid of using a hinge in the future. Just as a conclusion, follow an algorithm to work up the painful knee. Plan your procedure 1 versus 2 versus 3-stage type procedure. Debride, take a deep breath, and then debride some more. Consider your constraint level. Don't fear the hinge when it's indicated. Beware of that rotational constraint. So I see there was a question that was posted there. Why do you feel strongly about revising to the hinge in the setting of extensor mechanism? What is it they have well-fixed implants without infection or instability? So our success rate with extensor mechanism disruption is really poor without the use of a hinge. Most devices will have significant anterior-posterior laxity because you're missing your ACL. So if you don't have an ACL, you're going to strain that extensor mechanism. And for the extensor mechanism allograft, we definitely see more stretching out over time if you don't protect the anterior aspect of the knee with a hinge. So I would really strongly advise that if you're going to use an extensor mechanism allograft. Additionally, most of these people have had an extensor mechanism that's out for a period of time. So a lot of times these people come in and they're already more unstable than you think. Their MCL may be more stressed than you think. Their posterolateral corner may be more stressed. And certainly anterior and posteriorly, the capsule's stretched out. So again, I highly encourage you protect your extensor mechanism, protect your extensor mechanism repairs. I would even go as far as saying, even with the Marlex mesh, I think it's probably a good idea, although my experience for that is less than it is with the extensor mechanism allografts. What cement do I prefer for my spacers? Typically the cement that I will use for my spacers depends on the hospital that I'm at, because we have different cements at the two hospitals that I work at. I like to use a Palcos type of cement, which I'll use at one facility, and I'll use the plain cement when I'm making my spacer, and I'll go 3-to-1 with the antibiotics into the spacer, into the non-antibiotic cement. And then we have the Zimmer Biomet cement down at Rush, where we use that for our spacers. I just like the viscosity of the cement and the elution properties of Palcos. So that's why I typically will use that for my spacers. There's another question. What's your technique for revision components with stems? Do you fully cement them, or do hybrid only and cement the proximal portion? So when I'm planning a revision surgery for the knee, I typically look for 3 points of fixation. So I typically will look for getting something at the epiphysis, or the surface of the bone, something in the metaphysis, and then stem fixation. My favorite is, if they have good cortices, is to go to a press fit stem. And I prefer that. And certainly on the rotating hinges, I actually do like on-growth stems. They're almost impossible to get out, but they don't loosen. So I'll typically use press fit stems. I like that for my alignment. However, if it's an older person, I don't have a hesitation to fully cement on the stems. But when I do that, I want to, again, make sure that I get good fixation. So I will drill holes into the distal femur and proximal tibia to get cement indentation into the epiphysis. And then I will oftentimes use a sleeve or a cone to get metaphyseal fixation. And then my diaphyseal fixation will either be with cement, if I fully cement, or it will be with a press fit stem. And my preference for sleeves versus cones, I typically prefer cones over sleeves, because I like to put my cone in independent of where my implant is and then cement through. So I'm basically using my cone as my new cancellous bone. So I try to insert my implant into this new cancellous bone, which is the cone, and get good fixation that way. With a sleeve, you're usually attaching that to the implant, and you're not cementing through it. You're constrained to where your sleeve's going to go based upon your stem. If you're putting a stem in, that's going to drive you in one position or the other. And then in some of the sleeves, they don't detach from the implant, so that can make it very hard. The stem won't come through the sleeve, so it makes it very hard to get out. And so that's why I prefer the cones. I think they all seem to work in the data that I've seen. But overall, I prefer the cones, so I can cement through them and get fixation to my actual construct, and not actually have my sleeve be part of my construct itself where it's attached. Do we have any tips for removing well-fixed cones and long stems in the setting of infection? Yeah, I don't know if it's really a tip, but essentially what I'll do is, if I can, and I can detach the tibial tray from the underlying cone or the stem, then I'll take the tray off and I'll work from above. I'll use a pencil tip burr and go all the way around the cone, and then I'll use a back cutting curette and try to slap it out. And usually that'll work for the cones. I can get around them enough to do so. If not, then what I'll do is I'll go ahead and do a tibiotubercle osteotomy to take that out, so I can get some better access to the sleeve, and then to the cone, and I can smack it out from below. Same thing for the long stems. For a long stem, if it's a cementless stem, I'll trephine over it. If it's a cemented stem, usually the cemented stem comes out. It's a matter of getting the cement out. And depending upon what your next step is, if you're just cementing another implant in, you can leave that cement. If it's not, I'll ream the cement until it gets thin and then try to chip it out. And last ditch effort is I'll go ahead and just do a long tibiotubercle osteotomy, like an ETO, open up the tibia, clean it out, close the book back down, and cable that back. That isn't a great tip. I have cut tibial trays to gain access to the cones, but I think if you have any concern at all, rather than destroy the tibia and the extensor mechanism, better to do a tubercle osteotomy And if you have to go long, don't be afraid to go long. Those will heal back. What's your opinion of extracortical bone bridging? Extracortical bone bridging. I'm not really sure what you mean by extracortical bone bridging. I don't know if we can clarify that question. Next question is, what is your technique of tubercle osteotomy and revision? Do you use a saw bicortically and drill holes? Any tips or cables to repair? Not a lot of experience with passing cables around the tibia. Yeah, there's a ton of experience passing the cables around the tibia. I don't do a ton, maybe 1 or 2 a year, because usually we don't need it. But I will go ahead and for an extended tubercle osteotomy, I use an ACL saw blade. And then I will go ahead and take osteotomes, and just like an extended trochanteric osteotomy, I'll slowly lever it open on the other side. Because the tibia could have some pretty good cortices, you are going to have to hit that side pretty hard with some osteotomes, or I will just go ahead and go through with my ACL saw blade or fine pencil tip burr and score the other side so it does break. And the same thing as an ETO, I will make that distal cut with the horizontal cut with my pencil tip burr, and then go ahead and crack it open to lift up the tubercle. And that's going to be a big tubercle osteotomy. It goes all the way up to the epiphysis, includes the whole tubercle, and then a good portion of the cortices, so I can cable that back down. If I'm doing just a typical tibio-tubercle osteotomy, obviously I don't do that. I'm going to do more like Whiteside's, where I'm going to make that osteotomy and then hinge it open on the lateral side. But it's going to be relatively thin, and I usually fix it back with cables at the time of my revision. Sorry, not cables, wires, and I'll pass the wires around the stem of my implant so that it gains fixation and can't pull out of the bone. So hopefully that helps with the tip for the tubercle. You certainly can use drill holes. That's not a problem, but I use an ACL fine saw blade to do it instead. I think sometimes the drill holes make that gap a little bit wider. So the extracortical bone bridging was for porous collars on prostheses. So I'm guessing this is more for like distal femoral type replacement implants. So usually these porous collars, they just go up against the bone, and you can see some extracortical bone bridging into them. I don't know. I usually I would rather cement through or push it through, and have my porous collar actually in the bone. So there isn't a lot of options for that currently, but I think that would be the better options, to actually implant the porous collar and then cement through that your implant, so that you actually get great fixation of that porous collar. Right now, they just kind of sit up against the bone, and you're hoping to get that extracortical bone bridging, which occasionally we will see, but doesn't happen that frequently. Hopefully that helped answer that question there. All right. I don't know if there's any other questions.
Anyone else would like to ask a question?
Go ahead and send them in. If not, then I guess we can wrap it up. And hopefully this was useful for you to get a look at a typical workup for infection and failure of knee replacement, and then 1-stage versus 2-stage, and then using constraint.
Thank you very much, Dr. Levine. So he cannot hear us. Just if anyone has any questions, they can always email them over to Laura, and we can share them with Dr. Levine. If you want to take over just to wrap up, Laura.
Yeah, I will be sharing a recording of this webinar right after. And then, like I had said previously, the registration for the hip and knee IEP is open, and the page will come up right after this webinar.
One other question just came through. What are your thoughts on femoral cones? I think femoral cones are a good thing if you can get them in. The shapes are often sometimes difficult to fit in depending upon the implant that you're putting in. But yeah, it's great to get metaphyseal fixation on the femur as well, particularly on hinges. With hinges and the implants potentially being late, there's a little bit more stress on the femur. And so when you flex up, and usually what I'll do is when I'm putting in a hinge, I'll flex the knee up. And when I see the hinge starting to move. So I either see the tibia lift out of the tibia with the trial, or the femoral trial pulls out of the femur. That's the maximum range of motion before you're going to be putting a tremendous amount of stress on your implant. So I'll try to rebalance those implants to get maximal range of motion before you see that stress. And if I do see that stress, I definitely like to get cones on both sides to help restrain that stress, and definitely on the side where you're seeing the trial lift out of the bone.
Do you have any other questions before we finish up? Go through the question and answer or the chat. Okay, then we'll go ahead and wrap up. Thank you guys all for joining in today. And like I said, I'll be reaching out through email with a recording of the webinar, as well as the Hip and Knee website for the registration.
Thank you, everybody. Thanks, Dr. Levine, and thanks again to the team from Link Bio. Thank you, everyone.